Good morning. I'm Heather Mingo, and I'm the co-moderator for this session this morning. And I am a nurse practitioner in Halifax, Nova Scotia, Canada. And I've been there for 24 years since I started the program. We are a consult service that sees adult patients having surgery in both bloodless and blood management. We're an acute care, trauma, and transplant center. So we follow patients perioperatively, optimizing patients pre-op, follow them through post-op rounds, and we follow them about 6 weeks post-op or more. We are active in education with healthcare providers and patients, and we collaborate on research. Like I said, we're an active program. We see probably 90 to 100 new patients a month. So with Dr. Blaine Kent, our director, and Aaron Sampson, our nurse, we keep very busy. Having said that, I want to welcome everyone today to the fourth day of the Bloodless Medicine and Surgery Week 2024. It is organized by the Bloodless Medicine and Surgery Group for the University of Calabar, Nigeria, in collaboration with the Bloodless Medicine and Surgery Society and the Society of Advancement of Blood Management and the Malaysian Society of Blood Management. I would also like to recognize today, May 16th, as World Bloodless Surgery Day, in recognition of the pioneering work of the father of bloodless surgery, Dr. Denton Cooley, who carried out his first bloodless open heart surgery on May 16th, 1962, which is 62 years ago today. So a huge accomplishment. I'd like to now introduce and have the honor of introducing Dr. Bruce Spiess, Emeritus Professor of Anesthesiology at the University of Florida, United States, and a member of the BMSS and as well as the Society of Advancement of Blood Management.
Thank you, Heather. It's a great pleasure to join you this morning, as well as Nathaniel and this worldwide group of experts and dedicated people. Bloodless Medicine and Surgery Week is a great time for all of us to reflect. And I've dedicated the better part of 45 years of my career to trying to push this forward, and now has become not just patient blood management, but this bloodless medicine and surgery push around the world. It does make a difference. It makes a huge difference. The more and more I reflect upon it, the more I realize that this is doing something very, very positive for mankind. So we've got some great speakers today. My main goal is to remind you of a few housekeeping items. This is a virtual meeting, so you all know your exit routes should you have to exit. You all know where your bathrooms are, so I don't have to point out any of those to you. But I will point out to you to just remind everybody of our virtual etiquette, which is if you're not speaking, please stay muted. I have my dog sitting next to me, so I've got to make sure that as soon as I'm done speaking, I mute so that you don't hear him voicing his opinions on all these great lectures. The other thing is we're going to take question and answers after the lectures by the chat room. So please put any questions you have in the chat room. When we do have the question and answers, please raise your hand. Either I or Heather will call on you. I have the tremendous tendency to speak over somebody, and on a virtual meeting, that's not a good thing. So welcome everybody from around the world. I will shut up and we will let Heather introduce our first speaker, and I'm thrilled to have the speakers that we have here today. Thanks very much.
Thank you, Bruce. I have the honor of introducing our first speaker today, Dr. Lisa Newman, Professor of Surgery, Chief Breast Surgery Section, and Director, Interdisciplinary Breast Disease Program. She's the founder and medical director of the International Center for the Study of Breast Cancer Subtypes. She's an adjunct professor with MD Anderson Cancer Center. Dr. Newman is a surgical oncologist with a practice dedicated to breast cancer management. In August of 2018, she was appointed to oversee the breast program for the Weill Cornell Medicine New York Presbyterian Hospital Network. Previously to that, she worked at the Henry Ford Health System, where she served as a breast program director, covering many hospitals throughout Michigan since 2015. She's also the founding director of the International Center for the Study of Breast Cancer Subtypes. Dr. Newman has a primary focus in her research on race, ethnicity-related variation in breast cancer risk and outcome, the evaluation and management of high-risk patients, neoadjuvant chemotherapy, and special surgical techniques such as skin-sparing mastectomies and sentinel node biopsy. Her extensive disparities research has been published in many high-impact journals and was featured in a CNN documentary, Black in America Too. She's also been featured as a breast cancer medical expert for NBC's Today Show, as well as CBS Nightly News. She maintains a very active community service record and currently serves as the Chief National Medical Advisor for the Sisters Network, Inc., a national African-American breast cancer survivor support group. She oversees international breast cancer research and training involving the network of physicians and facilities in Ghana, Ethiopia, Nigeria, Uganda, Mexico, and the Caribbean. This program has focused on the study of triple-negative breast cancer in women with African ancestry. She's been acknowledged with many, many awards, such as the Top Black in Healthcare 2018, the Phenomenal African American Women of 2018, and many, many other accolades. With the most recent in 2023, she was named Physician of the Year for the New York Presbyterian Hospital Network. She's also been appointed to multiple national and regional leadership positions over her career, including the CDC Advisory Committee on Breast Cancer in Young Women, the NIH Clinical Trials Advisory Committee, and the Advisory Council to the National Institute of Minority Health and Disparities. Again, I have the privilege of introducing Dr. Newman, and she's going to be speaking on bloodless breast cancer surgery as a standard of care.
Thank you so much, Dr. Mingo. That was such an incredibly generous introduction. I apologize to everybody that I actually am speaking to you, as you can see, from the operating room here at Weill Cornell Medicine, but this is life in the 21st century. We have the privilege of being able to participate in all sorts of virtual meetings with the remote technology, but from every corner of the world and every corner of our workplace, as well as homes. So right now I'm in my workplace, but I'm not physically in an operating room with a patient. I'm just in a hallway outside of the operating room. So you'll see lots of action behind me. And I have to stay in my OR garb, including the cap, because of the obvious requirements in surgery. But it is an absolute honor to be able to join everybody speaking about managing breast cancer surgically with bloodless techniques. And so I'm going to try to share my screen. All righty. Is my screen appearing to everybody?
Yes.
Okay, wonderful. All right. So no surgery is totally bloodless, of course. Anytime you make an incision, you are going to have some blood loss, but you certainly do want to minimize that blood loss. And I won't go into the biology and the overall health benefits of minimizing blood loss. I will leave that to the experts that are participating in this incredible conference to do so. But I will talk about some techniques that I have come to appreciate over my several decades long career in surgery that are helpful in minimizing blood loss for breast cancer management. So these are the three basic topics that I will be addressing in this lecture: surgical technique, and I'll talk to you about my preferred technique in performing an axillary lymph node dissection, because when we do the axillary lymph node dissection in breast cancer patients, that is arguably one aspect of the surgery that can potentially put the patient at risk for the greatest amount of blood loss. And so meticulous technique can definitely achieve our goal of minimizing blood loss. In terms of surgical strategy and management of breast cancer, it's terrific when we can offer patients breast-conserving surgery, because lumpectomy surgery is definitely going to be associated with less blood loss compared to the broader surgical field of a mastectomy operation. But you always want to be thoughtful when you offer breast-conserving surgery to a cancer patient, and you only want to offer it when it's safe and feasible. We'll also speak briefly about lymphatic mapping and sentinel lymph node biopsy as a strategy for de-escalating axillary surgery in breast cancer patients, and the minimized targeted axillary surgery with sentinel lymph node biopsy is another way of minimizing blood loss. But just as with breast-conserving surgery, we have to prioritize management of the cancer, and so performing that de-escalated sentinel lymph node biopsy is only going to be appropriate in a well-selected patient. And then multidisciplinary breast cancer care is important. Many patients, especially on the continent of Africa, unfortunately present with locally advanced breast cancer. And when we can work closely with our medical oncology colleagues and downstage that locally advanced bulky cancer with preoperative chemotherapy, that can be another strategy that will make the ultimate surgery that the patient needs associated with far less blood loss. So first, let's talk about the axillary lymph node dissection. Here I'm depicting the anatomic lines for the incision in a woman that's undergoing breast-conserving surgery, and she requires an axillary lymph node dissection. The transversely oriented axillary incision will generally extend from the anterior axillary line to the posterior axillary line, and leaving the patient with a little bit of a gentle S shape in that incision can open up your field more widely to improve visibility and exposure, which can also minimize your blood loss. Now, I like, when I'm doing my axillary lymph node dissections, to start from inferiorly and laterally in my approach. Many people prefer to start with a superior approach where they identify the axillary vein first, and that is totally fine. My preference has always been to start inferiorly because I like to work my way up superiorly towards the axillary vein. I find that to be a safer technique in making sure that you identify all of your important neurovascular structures first, while you're dissecting out that lower level 1 area of the axilla, and then get to the axillary vein. I find that to be a more meticulous technique that gives you less blood loss. So on these next few slides, I'm going to show you two different perspectives, the observer perspective and the operating surgeon perspective, but the technique is obviously the same. So when I make that incision, I first identify the inferior aspect of the latissimus dorsi muscle, and I dissect out that entire anterior border of the latissimus dorsi muscle. Then, by reflecting the axillary level 1 contents medially over the latissimus dorsi muscle, I identify the thoracodorsal neurovascular bundle, which is depicted by the arrows here. And obviously, the thoracodorsal neurovascular bundle is going to be located on the belly of the latissimus dorsi muscle. And then I usually use a peanut to reflect that axillary 1 moving in towards the axillary 2 fatty contents, further medially and superiorly by pushing that peanut directly onto the thoracodorsal nerve and vein, so dissecting it out proximally, heading towards the axillary vein, which is the vein that the thoracodorsal vein enters into. Once I've reflected everything medially and superiorly, I like to identify one of the crossing veins that runs from the thoracodorsal vein over to the serratus anterior muscle. And where that crossing vein enters the serratus anterior muscle is almost always where you're going to find the long thoracic nerve running. So here I'm just demonstrating again the thoracodorsal nerve and vein, one of those crossing branches from the vein, and where it goes into the serratus, it's pretty much always where you're going to find that long thoracic nerve. So it's a nice, consistent landmark that allows you to find the second important structure, the long thoracic nerve, in a very safe and bloodless fashion. Then I continue my dissection superiorly, proximally, continuing to reflect all of that level 1 going into the level 2 axillary contents, further superiorly and medially, and identify where the thoracodorsal vein empties into the axillary vein. So now I've gone ahead and transected the level 1 and 2 axillary contents out of the field. And here I'm showing you the entire course of the axillary vein, the thoracodorsal nerve running out of the axillary vein, the thoracodorsal nerve running adjacent to the thoracodorsal vein. And here again, we have the entire length of the long thoracic nerve running along the serratus anterior muscle. I'm reflecting the pectoralis minor and major muscle here with the Richardson retractor, simply to show you that with this exposure, you can see very nicely the space of the level 2 and the level 3 contents. The level 2 axillary fat has already been resected with the level 1 contents, but with this exposure, you can palpate level 3, and if you do have any concerning lymph nodes or disease in that area, you can pretty easily resect it from this exposure as well. And again, this is a nice, safe strategy that allows you to protect all of your critical neurovascular structures while giving you beautiful exposure to all of the axillary contents that need to be resected in that cancer patient. So next, let's talk about a couple of other surgical strategies: breast conserving surgery and lymphatic mapping and sentinel lymph node biopsy as a de-escalated surgical strategies in managing breast cancer that can also result in minimized blood loss. Now, for any breast cancer, you do want to make sure that the local regional surgical management has addressed these basic principles. Number 1, you want to make sure that you've removed the primary focus of disease, the disease in the breast itself. But number 2, you want to make sure that you've resected not only the obvious disease that led to the biopsy and the diagnosis, but you also have to address the microscopic disease that's hiding in the breast tissue that looks completely normal surrounding the area that was biopsied. So we can achieve these first 2 goals by either doing a mastectomy or by doing a lumpectomy and then following that lumpectomy with breast radiation treatments. But the lumpectomy will definitely be associated with less blood loss compared to the mastectomy. So a lumpectomy is preferred in appropriately selected patients, but that selection is very important, as we will be addressing as well. The third principle of managing breast cancer is that we generally need to perform surgery in the axilla, both for durable local regional management of the disease, but also for staging information, because the pathology information regarding the extent of any disease in those axillary lymph nodes is going to be very important in planning the systemic therapy needs of that patient. On this table, I'm simply summarizing the several international studies that were conducted over the past few decades, documenting the safety of offering breast-conserving surgery to our patients compared to mastectomy. Now, these international studies had different eligibility criteria. Some of them allowed patients to participate if they had tumors in the breast as large as 5 centimeters in size. Others, such as the Italian study, were more restricted and only allowed patients to participate if they had T1 cancers. In all of those studies, we saw that overall survival, regardless of whether the patient was randomized to undergo the mastectomy surgery or if the patient was randomized to undergo the lumpectomy and the radiation, the overall survival between those two randomization groups was equal within each study. Some studies, the ones that allowed patients to participate if they had larger size tumors, did have lower survival rate compared to the studies that only allowed the smallest size tumors to participate, because the smaller size tumors were associated with an earlier stage of disease, of course. And what we also observed is that in terms of local recurrence, you do see some differences in terms of higher recurrences in general for the women that undergo breast conserving surgery, but not with huge differences actually in local recurrence, but definitely you do see higher rates of additional breast events in the women that undergo lumpectomy surgery. Those women can have regrowth of the original cancer, which will typically occur at the tumor bed within the first 5 years after surgery. But for the rest of that woman's life, she's also facing the risk of developing a completely new primary breast cancer, which will also contribute to the rates of additional breast cancer events in that woman's lifetime. But the survival rate is going to be driven by whether or not we are able to control the microscopic metastatic disease that has disseminated hematogenously to other organs, the liver, lungs, bones. And that micrometastatic hematogenous dissemination happens before we've even made the breast cancer diagnosis. It is not affected by whether the woman has the mastectomy or the breast conserving surgery. The overall survival rate is determined by whether or not our systemic therapies are successful in eradicating the distant organ micrometastatic burden. The NSABP B06 trial, which is shown in the row at the bottom of this table, actually had a third randomization arm where some women were randomized to undergo the lumpectomy surgery without the radiation. And we saw from that trial that the rates of having additional events, cancerous events in the treated breast itself, were 4 times higher if the women did not receive radiation. So in general, we think of lumpectomy as going hand in hand with radiation, where we rely upon the radiation to eliminate the disease that's hiding in the remaining breast tissue after the lumpectomy was performed. But again, we do want to be very thoughtful about the patients that we choose to offer breast conserving surgery to, because we don't want our patients to be a setup for excessively high rates of additional cancer in the breast, despite the fact that the survival will be equivalent for mastectomy versus lumpectomy. So number one, you do need to have a patient that is comfortable with breast conservation. And here in the United States, we actually see a fair number of women who, even though they have small tumors in the breast and we offer them lumpectomy surgery, sometimes those patients prefer to undergo bilateral mastectomy even, because here we do have really good reconstruction options that we can offer those women at the time of the mastectomy. And many of our patients, especially the young patients, opt to undergo bilateral mastectomy and reconstruction because they want to lower the chances of getting a totally new breast cancer, where they would have to start all over again with that breast cancer diagnosis and treatment experience. We mentioned the importance of radiation, and so it is important for your lumpectomy patients to have access to a radiation facility. And if you do not have access to radiation, then that patient is probably better served by a mastectomy. Similarly, the patient should not have any contraindications to radiation. You want to have a reasonable ratio between the tumor size and the breast size, because if the woman has a relatively large tumor, but a modest-sized breast, she might have an unacceptable cosmetic appearance when you've achieved your margin-negative lumpectomy and then subjected the breast to the shrinkage, the fibrosis from the radiation treatments. But the woman has to be the patient, the one to decide the acceptability of the cosmetic appearance. And we as surgeons have to simply counsel the patients regarding what we think the likely cosmetic appearance will be. It's really, really important to have good, reliable mammography preoperatively in our lumpectomy candidates, because sometimes the mammogram will show you areas of disease that need to be resected, but that aren't clinically evident on examining that patient. So you want to make sure that the mammography does not show diffuse malignant appearing microcalcifications in the breast. You want to make sure that the woman doesn't have multiple tumors sprinkled throughout the different quadrants of the breast, because those can be patients where the radiation treatments will be less effective and where you are less likely to be able to achieve a margin negative lumpectomy. And getting those negative margins is critical. If your lumpectomy does not have negative margins, then you need to return that patient to the operating room for a re-excision lumpectomy, or you need to counsel the patient to undergo mastectomy. So now let's make a few comments about de-escalating axillary surgery with the concept of sentinel lymph node biopsy and lymphatic mapping. The axillary lymph node dissection, which we discussed initially, is again a very definitive operation for controlling the axilla in breast cancer patients, but it is associated with the long-term postoperative morbidity of lymphedema, loss of sensation in the skin of the underarm and the posterior aspect of the shoulder. And some women will have shoulder dysfunction where the shoulder is very stiff after the surgery. Lymphatic mapping and sentinel lymph node biopsy is a terrific, accurate way of identifying the lymph nodes most likely to be involved with cancer if the breast cancer metastasized through the lymphatic system. And so the sentinel lymph node biopsy has now become a widely accepted option for accurately identifying patients that have node negative disease at presentation. So this is simply depicting the concept of the sentinel lymph node biopsy. You want to be able to inject an agent in the breast that will map the lymphatic system. So that agent can either be a technetium-labeled sulfur colloid solution, an isotope solution, which is depicted over here, where you see that, or it can be a blue dye, such as methylene blue or isosulfan blue. And usually we inject that mapping agent in the subareolar region because most of the breast will map through the intramammary lymphatics, moving up to the subareolar plexus of Sappi, and then head out towards the axilla. So you can standardize the mapping by injecting everybody in the subareolar region. But the concept is that the agent that you use will travel through the intramammary lymphatics before settling in those first most important lymph nodes, the sentinel lymph nodes. And in these photos, I'm showing you a nicely stained blue lymph node. And down at the bottom here, you can see the large, bulky contrast from the isotope and the scan. But the sentinel lymph node is a nicely stained lymph node that you can detect with your Geiger counter in the operating room. And this table is simply summarizing results from many different studies that were conducted in the 1990s when we were first exploring the concept of lymphatic mapping and sentinel lymph node biopsy for breast cancer. And in all of these early years, we did the sentinel lymph node biopsy, but we also did a backup concomitant axillary lymph node dissection so that we could determine our accuracy and false negative rates, in addition to documenting our identification rates. And by the late 1990s, going into the 21st century, we were able to get our identification rates pretty consistently in the high 90 percentiles, and we were able to get our false negative rates down to under 5 to 10%. So by the time we got into the 21st century, we felt very safe in offering women a sentinel lymph node biopsy as a lower morbidity alternative to the full axillary lymph node dissection. But again, you want to be thoughtful about when you're doing a sentinel lymph node biopsy. And in some settings, such as in regions, as in many, unfortunately, areas of Africa, patients do continue to present with bulky axillary disease. And in that setting, a sentinel lymph node biopsy is going to be inappropriate. You will often need to do the standard axillary lymph node dissection in order to achieve a durable local regional control of the disease in that type of a scenario. For women that can receive neoadjuvant chemotherapy, if they've presented with bulky axillary disease, that can be a terrific way of downstaging the axilla. And then after you've downstage the axilla with the neoadjuvant chemotherapy, some of those patients will be a candidate for sentinel lymph node biopsy. But if the sentinel lymph nodes do show residual disease in the axilla, those women need to undergo the completion axillary lymph node dissection. Again, if you don't have access to the lymphatic mapping technology, the patients that receive neoadjuvant chemotherapy will have a safer axillary lymph node operation because their disease has been downstage, but they might still need to undergo the standard level 1 and level 2 axillary lymph node dissection. Lastly, for bulky axillary disease that is unresectable because it's fixed to neurovascular structures, in those patients, if you don't have access to neoadjuvant chemotherapy, you might need to rely upon primary radiation therapy to try to control that bulky axillary disease. So now, lastly, let's talk about the concept of downstaging locally advanced breast cancer with neoadjuvant chemotherapy as the final strategy for performing surgery that has minimized blood loss. But again, downstaging that breast cancer with neoadjuvant chemotherapy should be a decision approached with thought and rationale. So you only want to offer neoadjuvant chemotherapy to women that have a clear-cut indication for needing chemotherapy based upon their initial diagnosis. So, for example, we would never offer neoadjuvant chemotherapy to a patient that presents with ductal carcinoma in situ, because those patients would not need any chemotherapy at all. They have a very low risk, minimal risk of having any micrometastatic disease in distant organs. So for ductal carcinoma in situ, we offer surgery to the breast, but no chemotherapy. And this is just a photo depicting a beautiful response in one exemplary patient that had a bulky disease in the upper outer quadrant of her breast, and the neoadjuvant chemotherapy very nicely melted away her disease. So neoadjuvant chemotherapy is definitely the standard of care for women who present with inoperable disease, as defined by having a locally advanced bulky or fixed cancer on the chest wall, and for patients that present with primary inflammatory breast cancer. We learned from this experience of using neoadjuvant chemotherapy to treat locally advanced breast cancer and inflammatory breast cancer that preoperative chemotherapy indeed will be successful in the majority of our patients in downstaging the disease in the breast and also in the axilla, so that it makes our surgery easier. And response to that chemotherapy is a great prognostic feature. If you see the disease in the breast shrinking down with the chemotherapy regimen that you've chosen, you can be pretty sure that your chemotherapy regimen is achieving the ultimate goal of eradicating the micrometastatic disease that the woman has in distant organs, the liver, lungs, bones. And that's going to be the key to better survival rates. If you don't see the desired downstaging of the disease in the breast with your selected neoadjuvant chemotherapy regimen, then that might be an opportunity to switch your chemotherapy regimen to an alternative regimen so that you stop giving the patient the toxicity of an ineffective regimen and hopefully can identify an alternative treatment that will be more effective for that patient's disease biology and more effective in shrinking down the disease so that the patient can have a better operation. Lastly, we are now using neoadjuvant chemotherapy very aggressively in drug development fields and using that prognostic information from the treatment response to identify early on the patients that are benefiting from a novel chemotherapy or systemic therapy regimen. And we'll talk about that again in one of the final slides. Here, I'm simply summarizing several studies that were conducted internationally where women with different stages of breast cancer were randomized to either receive chemotherapy preoperatively or to receive chemotherapy postoperatively. And we do see that the preoperative chemotherapy patients are more likely to undergo breast conserving surgery with reasonably low local recurrence rates. And we see that in terms of overall survival, there is no difference in survival outcomes for the patients randomized to receive preoperative chemotherapy compared to receiving postoperative chemotherapy. And so preoperative chemotherapy and the surgery that's being done later is not resulting in a survival disadvantage for the patients. In the early years of exploring neoadjuvant chemotherapy, many people were worried that delaying surgery would result in a survival disadvantage, but that is clearly not the situation. So again, you want to select patients properly for neoadjuvant chemotherapy. And if the woman has a bulky cancer in the breast or in the axilla, that might be the indication for neoadjuvant chemotherapy. It's also a good idea to rely upon the disease phenotype in identifying neoadjuvant chemotherapy patients. So the triple negative breast cancer patients, the HER2 positive breast cancer patients are going to be the better candidates for neoadjuvant chemotherapy, and in the setting of HER2 positive disease for targeted anti-HER2 treatments. Patients that have hormone receptor positive and HER2 negative breast cancer, if they are clinically node negative, sometimes those patients can be offered neoadjuvant endocrine therapy. We can optimize the benefits of neoadjuvant chemotherapy by making our cancer diagnosis on the basis of an initial diagnostic core needle biopsy rather than excising the primary tumor in the breast so that we have measurable disease remaining in the breast. Again, it's really important to have good, reliable mammography at the time of diagnosis so that we can monitor our chemotherapy effect and so that we can better plan the surgery after the neoadjuvant chemotherapy has been delivered. And this is just a photo depicting the importance of that pre-treatment and post-treatment mammography. When you have resources available, it's best to make sure that there is a clip inserted at the site of the initial diagnostic biopsy, because if the woman does have a complete response to her chemotherapy and you want to offer that patient a lumpectomy, you have to be able to localize to find the site of the disease that was initially diagnosed through biopsy. You also need to rely upon the mammography to determine whether or not the patient has had any unmasking of microcalcifications during the chemotherapy treatment, which can also impact on the subsequent surgical plan. And then again, lastly, today we do rely upon neoadjuvant treatment to identify novel systemic therapies that are appropriate in a faster way. When we give chemotherapy after surgery, the only way we know whether or not the disease has responded is when we see whether or not the woman developed metastatic disease. And so in clinical trials, that can actually take many thousands of patients to prove after many years of follow-up. But with neoadjuvant treatment, we can monitor the effectiveness of the therapy within a few months simply by looking at whether or not the breast disease is shrinking down. And so I'm going to stop there, but I do thank everybody for their time and attention. And I bring you greetings from Weill Cornell Medicine and the New York Presbyterian Hospital Network.
Thank you very much, Dr. Newman. This is Bruce Spies out in California, a little ways away from you. But I'm going to ask you, would you like to take some questions now, or would you want to come back later in about an hour and a half to take questions?
I think I'm not sure that I'll be able to come back later, but I maybe have another couple of minutes before I have to head back into the operating room.
So I will ask anybody to put any questions in the chat room, and we'll take about 5 minutes for questions. I had one question I was going to ask you, which was when Neil Blumberg first spoke on this initiation of this meeting on Monday, he noted that if you transfuse patients during cancer resection, the incidence of early metastases and enhanced mortality goes up dramatically, but not so much for breast cancer. It seems like breast cancer stands out differently. Do you have any explanation for why that might be? Why what we see as essentially an immunosuppressive effect for many other cancers doesn't seem to make that much difference in breast cancer? Any thoughts?
That's a great question, Dr. Spies, and I'm not going to pretend to be an expert in understanding the biology of transfusion and how it impacts on the immune response of the body to a cancer, but I do believe that it is very real. If the data are showing a lesser impact on breast cancer, that is probably a testimony to the effectiveness of our systemic therapies for breast cancer. We deliver adjuvant systemic therapy to the high majority of our breast cancer patients, and these systemic therapies have just advanced wonderfully over the past several decades. And so that, I believe, is the strategy that is mitigating any impact on the immune response and how that immune response might be suppressed by transfusions. So the difference in breast cancer, I would say, is a testimony to the advances in systemic therapy.
Okay, great. Thank you. We have one other question in the chat room from David Jadwin out in Canada. I'm unable to submit. Anyway, he says, during breast surgery, how often do you have to resort to RBC transfusion? And if so, what criteria do you require to actually do that?
Yeah, well, in more affluent countries, the US, Europe, Canada, westernized countries, we fortunately have many resources intraoperatively and preoperatively that allows us to make intraoperative transfusion and perioperative transfusion a very rare thing. Most of our patients are fairly healthy and robust when they go to surgery, and we are able to minimize the duration of the surgery, minimize the blood loss with the terrific surgical instruments that we have, and we have great anesthesia colleagues so that patients are supported well. So it's pretty uncommon to require transfusion in the course of breast cancer surgery. I would say that it's probably 1 to 2% of the time do we need to give transfusion in a cancer patient. For reconstruction, we do a lot of deep flap reconstructions, and those cases are somewhat more likely to require transfusion. I can remember a couple of decades when we were first utilizing the deep flap reconstructions with our plastic surgeons. Patients used to routinely donate their own blood in advance of the surgery in case they needed a transfusion, but that's pretty much disappeared completely because even with those deep flaps, it's really uncommon to need a transfusion perioperatively.
Great, and thank you for a wonderful lecture.
Oh, Bruce, there is one other message in the chat there from Philip Jones.
I'm not seeing it. If you want to read it.
He asks, I know it's hard to answer, but what is the average blood loss depending on breast cancer surgery?
Oh, thank you. Great question. For lumpectomies and sentinel lymph node biopsies, the average blood loss is probably less than 10, 15 cc's. With a mastectomy, that probably goes up to more like 25, 50 cc's. If it's a mastectomy with reconstruction, potentially it could be more in the range of 50 to 100 cc's, but still fairly minimal. A deep flap can have more in the range of a few hundred cc's of blood loss, primarily because of the abdominal and the intrathoracic dissection, but still generally it's going to be a lower volume blood loss with breast cancer surgery compared to many abdominal and GYN pelvic operations.
Okay. I do work
in Africa. Oh, I'm sorry. I was just commenting that I have the honor of partnering with several colleagues in Africa several times a year. So I take care of breast cancer patients surgically in Ghana, Nigeria, and Ethiopia. And unfortunately, many of the patients have much bulkier disease there when we are operating on them. They may be more frail in preparation for surgery. And sometimes we just don't have the best functioning cautery equipment to use. And in those settings, the blood loss can be double or triple of what we see in some of our more affluent settings. So trying to be as meticulous as possible will be very, very important in those resource constrained settings.
Philip also asked, does neoadjuvant chemotherapy impact due to potentially lowering blood levels when you need to optimize blood levels before surgery?
Thanks. So we still typically rely upon the absolute neutrophil count as being the benchmark for when we can operate on a patient following the last course of neoadjuvant chemotherapy. Today, most patients, if they are experiencing neutropenia related to chemotherapy, they will get the bone marrow supporting agents. So it's pretty uncommon to see patients that have low blood counts, resulting in a delay in being able to offer surgery. Most patients will undergo surgery about 3 weeks. Sometimes it can be up to 6 weeks after that last neoadjuvant chemotherapy infusion before they can have surgery, but perfectly safe to offer the surgery 3 weeks after that last chemotherapy, when we can be fairly confident that the bone marrow will have recuperated from the chemotherapy effects.
Do you have time for a couple more, or do you have to run?
I probably should head back now. I do have to mark my next patient, but I will definitely try to return later on. I'm going to keep my screen turned on, but I will go on mute and I'm going to stop my video. But thank you so very, very much again. I will try very hard to return a little bit later.
Thank you so much for your time and a wonderful lecture and answering the questions. We really appreciate it.
Thank you. Thank you very much.
Good luck with the rest of your day and your surgeries today.
Thank you.
I'm going to move us on. Unfortunately, Jonathan Waters is not going to be able to join us. He's stuck in surgery also. So our lovely leader, Nathaniel Lucero, has stepped forward and is going to deliver a lecture about bloodless breast cancer as the standard of care. So we're going to have that as an audible here and go with that. So Nathaniel Lucero, I think, is known to all of us, but is Chief Consultant General Surgeon at University of Calabar Teaching Hospital in Nigeria. He's a fellow of the West African College of Surgeons and a fellow of the International College of Surgeons. He's served a full tenured position as head of surgery in his institution, during which time he's instituted the teaching of bloodless conservation and bloodless surgery to many medical students and residents. And I would say he actually leads the world in this and how passionate he is and what he's managed to accomplish. Dr. Osuro is the founding chairman of the Bloodless Medicine and Surgery Group at University of Calabar, a multidisciplinary group of professional volunteers providing bloodless care for patients, having excellent outcomes since 2007 as their inception. He's a member of many international professional societies, including Society for the Advancement of Blood Management, where he serves in a membership committee, and he's the founding president and current president of BMSS. He's a passionate about improving clinical outcomes, spreading the word around the world in terms of how well patients can do with this kind of thoughtful care and technique. He's a recipient of several awards, including the 2016 SABM Kathleen J. Sasma Award for Outstanding Leadership in Advancing Patients' Rights and Patient Blood Management. I am very honored to have the chance to introduce him. And Nathaniel, thank you for both making this happen, these meetings happen, as well as your passion, plus stepping in here to fill a void. Nathaniel, it's yours.
Thank you so much, Bruce. I need to mention that Dr. Spies is my teacher when it comes to bloodless care. And Dr. Newman came to Nigeria to teach us breast cancer surgery. So I have the best of both worlds. And since Dr. Newman has already spoken about a lot of the technical stuff in breast cancer surgery, I would just say a few words more on the bloodless side, as she has already said I should. So I do not have any disclosures, and I am certified in fundamentals as well as advanced concepts of patient blood management. Like I said, good teaching from SABM and from Dr. Spies. I'm also certified in bloodless medicine and surgery, even as recently as 2019. So having shared a bit of my credentials in bloodless, we want to see how we can explain what is wrong with blood transfusion in oncology. Thankfully, people who are better than me have done that already. On Monday, Dr. Blumberg spoke on that, and Dr. Refa also spoke on Tuesday. But we'll sort of review a few of the things they said. And we'll outline the principles of bloodless surgery and their application in breast cancer surgery, and then explain the benefits of bloodless care and why it should be the standard of care in breast cancer surgery. So breast cancer is the commonest malignancy of females worldwide, and about 25.1% of all cancers in females worldwide is breast cancer. Even in my setting in Calabar, it's even worse. 41.1% of all cancers in females, the Calabar Cancer Registry. And in my setting, it seems to affect mostly younger women, premenopausal. It's the commonest cause of death from malignancy in females worldwide after lung cancer. So why do breast cancer patients get transfused? Again, we had an idea of this earlier in the week, that cancer patients have anemia from disease, surgery, or chemo. And sometimes they suffer blood loss, could again be the disease. Breast cancer patients, like the advanced breast here that we see around here, they do bleed. And the surgery, of course, can lead to hemorrhage. So what do you mean by standard of care? The NCI, in the Dictionary of Cancer Terms, defines standard of care as a treatment that is accepted by medical experts as a proper treatment for a certain type of disease, and that is widely used by healthcare professionals, also called best practice, standard medical care, and standard therapy. Hitherto, it would have seemed that blood transfusion was like standard of care, but we're going to see why that title is slipping away from blood transfusion, going to bloodless care. So what is bloodless medicine and surgery? It is the provision of quality healthcare without the use of allogenic blood transfusion, with the aims of improving clinical outcomes and protecting patients' rights. So we are probably more familiar with the aspect of protecting patients' rights, but as we shall see, we have migrated from that, and you'll see why. So it's synonymous with transfusion-free medicine and surgery, and it encompasses, when we say bloodless medicine, we also mean bloodless surgery. And it's sometimes expressed as bloodless medicine or bloodless surgery. It's a multi-modal, multidisciplinary application of techniques tailored to the individual patient following a protocol. So it's not a one-man show. Neither is it one single technique, but a combination of techniques. Again, emphasis now is on improving clinical outcomes. And this early literature, the article in Transfusion by Goodenough and Shanda and Spence, defined bloodless medicine as referring to emerging clinical strategies for medical care without allogenic blood transfusion, a well-defined area in blood management. And this article by Martin and colleagues in the Theory and Practice of Bloodless Surgery rather entitled The Theory and Practice of Bloodless Surgery in Transfusion and Apheresis Science, defined bloodless surgery as a comprehensive perioperative approach that has as its goal allogenic transfusion avoidance with a view to improving patient outcome. So you can see the issue of improving outcomes has come into bloodless medicine and surgery. The authors admit that it was initially an advocacy, but they pointed out that it is a safe, effective team approach to medicine and surgery that reduces blood loss and uses the best available alternatives to allogenic transfusion therapy while focusing on the provision of the best possible medical care to all patients. Now, when you're providing medical care to all patients, that is no longer, you're not talking about an advocacy, you're not talking about patients who decline blood transfusion. So we are now moving towards standard of care. And why so? The same article says that recent evidence suggests that the application of bloodless surgery principles may result in improved patient outcomes, reduced morbidity and mortality, shorter hospital stays, significant overall cost savings to the health system. Does this apply to breast cancer patients? Certainly, we shall see. The article also points out that it was Denton Cooley and his group that actually popularized or rather advanced bloodless surgery, because they did what one did not think was possible, to do open heart surgery without transfusion. And unfortunately, it wasn't widely accepted because there were negative connotations attached to practice, seen as being associated with a fringe religious group. This is my own bit of contribution in a textbook of blood transfusion in clinical practice, defining bloodless medicine and surgery as the provision of quality healthcare to patients without the use of allogenic blood, with the aim of improving outcomes and protecting patients' rights. So again, the issue of improving outcomes. And of course, if we are able to improve outcomes, then we are dealing with something that should be a standard. Not surprisingly, the WHO came out with this policy brief, urgent need patient blood management. And they pointed out that the concept that our own blood is still the best thing to have in our veins has given rise to various surgical blood conservation techniques. Underlying these efforts is the broader concept of patient blood management. And they talked about the development, how it evolved. You can see those three pillars of patient blood management from the World Health Organization. Where did they get the three pillars from? Well, it was actually from the work of Dr. Denton Cooley in bloodless surgery. And you can see here the global definition of patient blood management by Shanda and colleagues, published in 2022, defining patient blood management as a patient-centered, systematic, evidence-based approach to improve patient outcomes by managing and preserving a patient's own blood while promoting patient safety and empowerment. Does that sound to you like bloodless surgery? If it does, it's because that's where it came from. As you can see here, that again, Dr. Denton Cooley is highlighted as having been the father of bloodless surgery, starting with Jehovah's Witnesses. And the three-step approach he used, now adopted by the World Health Organization and called patient blood management. So basically, this approach has led to a better outcome for patients, whereas blood transfusion, as you can see, it's in this article, there has been mounting evidence that blood transfusion is independently associated in a risk-adjusted dose-dependent relationship with increased morbidity, mortality, and hospital length of stay. So that doesn't sound like what should be referred to as standard of care. If something is increasing the mortality, morbidity, and length of hospital stay. And so hence the tendency now for everyone to move away from blood transfusion, including in breast cancer surgery. So if you look at the definition of bloodless medicine and surgery and PBM, you can see the similarities. Bloodless medicine and surgery talks about quality healthcare, so it's not substandard care, while PBM talks about patient-centered, systematic, evidence-based care. And bloodless medicine and surgery talks about not using allogenic blood. And PBM talks of preserving a patient's own blood. And BMS talks of improving clinical outcomes. And the same thing with PBM. Then protecting patients' rights, which was where we started. That is patient autonomy and advocacy. That's where we started from. And the PBM is indicated as promoting patient safety and empowerment. So what is wrong with blood transfusion? Well, we are probably familiar with the hazards. Some may not realize that the hazards are different from the adverse outcomes. And then how many people know about the lack of efficacy? And is it really evidence-based? Is it ethical? Is it ethical, blood transfusion? Those are questions we need to think about. So we know about hazards, danger, risk, peril, threat, menace, jeopardy, chance, probability. We can take a chance, like crossing the street, which may be dangerous, but we cross the streets anyway. So doctors are used to balancing the hazards with the benefits. We have infectious hazard, non-infectious serious hazards of blood transfusion. The challenge comes when there is no evidence of benefits, as we shall see later. So we know a bit about the hazards of blood transfusion, and we may not need to go through each and every one of them, but there's quite a long list. And even the transmission of infection alone is a very big list. In my country, 95% of donor blood units are said to be unsafe. There's a warning by the experts, WHO, the medical authorities in Nigeria. Why? Because there are lots of transfusion transmissible infections, and a lot of them are endemic in my setting. And how many of them do we test for? It's only 4: HIV, hepatitis B and C, and syphilis, out of that long list. Now, let's move away from the hazards and talk about the adverse outcomes of blood transfusion. Should it be the standard of care? What are adverse outcomes? It's an unintended and unwanted event or state occurring during or following medical care that is so harmful to a patient's health that adjustment of treatment is required or that permanent damage results. That's not something we want. All doctors, we don't want to harm our patients, and we don't want any permanent damage resulting. Now, there is adverse outcome of blood transfusion. There are adverse outcomes of blood transfusion, oncology, and breast cancer patients are not exempt. If you look at this early study by Crow et al. In 1989, they checked on transfused node-negative breast cancer patients. Those are patients that we would expect would have good outcomes because they are node-negative. But they noticed a decreased disease-free survival and overall survival. Subsequently, Bush et al. In 1994 reported 420 patients who had curative resection for colorectal cancer, curative resection, but they had higher local recurrence among those transfused, poorer disease-free survival. And both preoperative autologous donation and allogenic blood transfusion were associated with poorer prognosis. And Van der Watering et al. Also found in transfused colorectal patients lower 5-year survival. So transfusion is bad news in oncology, including breast cancer. Even when the blood is leukocyte depleted, it has been found that there's still increased problems like post-op ventilation rates, prolonged hospital stays discovered by Scanbeck et al. 2007, and Sojita et al. 2008, found in hepatocellular carcinoma resection patients lower 5-year survival. And they can actually have a risk of developing non-Hodgkin's disease, a different cancer entirely. So this article talks about blood transfusion promoting cancer progression. And that is something we don't want. So adverse outcomes of blood transfusion in oncology include increased post-op ventilation rates, prolonged hospital stay, reduced disease-free survival, higher recurrence rate, reduced overall survival, poorer prognosis, and increased risk of developing other cancers. The Society of Thoracic Surgeons have let us know recently, this is 2023, just last year, that even when we transfuse just 1 or 2 units of blood, there is still higher mortality, higher incidence of stroke, prolonged ventilation, renal failure, and reoperation, compared with patients who receive 0 RBCs. So those patients who receive 0 RBCs, what kind of surgery do they have? That's bloodless surgery. And so they concluded that this low volume transfusion is strongly associated with higher morbidity. This is just last year's publication. So should this be the standard of care? Certainly not. And we see here a question: why does intraoperative blood transfusion lead to worse outcomes? Well, mainly due to storage lesions and immunomodulation. And storage lesions, as we learned from Dr. Refai, lead to reduced tissue oxygenation. We tell our patients we're going to transfuse you so that to improve your tissue oxygenation, but it does the opposite. And was viscosity, aggregability, coagulopathy, a lot of problems come. Change in the morphology, and even the biochemical changes all lead to hypoxia, which this elegant study by Togeman and colleagues shows that the SpO2 is reduced in transfused patients, and it goes beyond just after 24 hours. So why are we transfusing them? We promise that we're going to improve their tissue oxygenation. I borrowed this slide from Dr. Spies. There can be up to 400% reduction in oxygen delivery due to transfusion. So immunomodulation is another big problem, leading to trialing, immune infection, cancer recurrence, and so on. And this is another borrowed slide showing that immunomodulation may actually be a #1 cause of death in transfused patients. An attempt is made in this slide and article to try to figure out why this happens. And there are lots of mechanisms which we may not go into, but the point is that there's increase in cancer recurrence rates by what percent? It can be up to 80% in colorectal cancer. And of course, post-op bacterial infections by how much? 200 to 1,000% in some studies. Does this affect breast cancer patients? Definitely. So it cannot be the standard of care for us to be transfusing. 100% of our patients have some form of immunomodulation or the other. And 100% of our patients have some level of decreased oxygen delivery. So we're talking like poorer prognosis in oncology. We're talking of higher infection rates, increased hemorrhage, higher incidence of ICU admissions, higher morbidity, greater length of hospital stay, and higher mortality. And of course, there's a lack of efficacy. If it's causing hypoxia instead of improving tissue oxygenation, and higher morbidity instead of lowering, and increasing mortality instead of lowering. So there's more that is known about the risk of blood transfusion than the benefits. This article in the Current Opinions in Anesthesiology said the benefits of blood transfusion have never been conclusively demonstrated, but evidence of transfusion-related harm continues to accumulate. So if there's no benefit, we're now moving beyond the issue of autonomy, which is still relevant, because as Dr. Blomberg pointed out, if we should have to tell our patients all the problems of blood transfusion, would they actually take a blood transfusion? So we just gloss over and tell them you need it to make you better. But if there's no benefit, then the issue of beneficence in medical ethics, that aspect is violated by blood transfusion. And if it is actually causing harm, higher morbidity, higher mortality, then non-maleficence has been violated. And if we only give the best to patients who decline what is causing adverse outcomes, are we being just? So we need to apply justice. If we know that some kind of therapy is beneficial, we should use it for all patients. So again, we noted why the breast cancer patients get transfused, but we also note that it doesn't really solve their problems. It makes things worse. Far back 2002, the World Health Organization told us that if we use simple alternatives to transfusion, even IV fluids, it's safer, less expensive, and maybe equally effective. A recent study, I think it was last year, published in The Lancet, compared transfused patients with hemorrhagic shock with those who were given normal saline. Shockingly, there was no benefit found in people in shock due to hemorrhage from trauma. So that brings us to bloodless medicine and surgery. And we can see those three pillars that Dr. Denton Pooley had enumerated or had pointed out: optimize hematocrit, minimize blood loss, support patient tolerance of anemia. And in bloodless medicine and surgery, we add optimized tissue oxygenation, which I think the anesthesiologists among us will be very happy about. So we already have heard much about optimizing the hematocrit, how we can use iron, that's the central thing, oral iron when possible, when feasible, parenteral, nutritional support, ESAs. We use them in our patients, breast care patients, including oral iron. Yes, it might not be very effective, but the background, we have found that, like in this patient, 55-year-old, who was started on oral iron from first visit, by the time we were set for surgery, our HB was 13.5. Before that time, it was around 10. But we use IV iron a lot. It's quite standard. We use it for every cycle of chemo and also perioperatively. This is that same patient had 6 cycles of chemo and maintained the PCV well, because each cycle we give IV iron. There's a series of patients that had chemo and IV iron with each cycle. The question here, should intravenous iron be the standard of care in oncology? I'm sure we'll agree that yes, it should be. The issue of ESAs, Dr. Ford did justice to that on Tuesday. We have to be cautious. We will always give IV iron with ESAs, and we do not use ESAs in cancer if the hemoglobin is more than 12 grams per DL already. And we don't use it for cancer anemia due to disease only. That doesn't stop us from using IV iron. Though we know that when we add, adding IV iron to ESAs improves chemotherapy-induced anemia. So minimizing blood loss is important. I think Dr. Newman has said some bit on that. Starts right from the history. Want to know about bleeding disorders and address them. Stop medication that may cause bleeding during surgery. Restrict phlebotomies. Use tranexamic acid, very important. Perioperatively, vitamin K and others. Non-invasive monitoring. Intraoperative techniques. of which we want to emphasize meticulous hemostasis. We saw a presentation Dr. Newman gave and how she goes about detecting very carefully. So in that outpatient pre-op HB was 13.5 grams per DL, third day post-op 10.6 grams per DL, using as many of those techniques as possible. So we do optimize tissue oxygenation, giving oxygen therapy when necessary. Even if the patient seems to be stable, but hemoglobin is less than 6 grams, we may give oxygen and then wean the patient off period. We replace volume, crystalloids and colloids. Colloids when the blood loss exceeds 25% of blood volume. And we try to resuscitate to the lower level of normal people. We make sure pain is taken care of because that can cause hypoxia, and sepsis, malaria, or any other underlying infections are treated. Very rarely do we use inotropic vasoactive agents. And of course, artificial oxygen carriers are experimental. And right, so we support the patient's physiological tolerance of anemia. WHO says we should do so. So we institute measures to ensure hemodynamic stability. We correct any electrolyte disturbances, limit patients' activity in moderate to severe anemia. Use point of care testing as much as possible. And we recognize that blood transfusion poses greater danger than anemia, and that with adequate support, patients have survived extreme anemia better without blood transfusion. I mean, it stands to reason if blood transfusion is causing hypoxia, then avoiding it would always be better. So faster recovery post-op, faster wound healing, lower wound infection rates, lower mobility, fewer ICU admissions, shorter hospital stay, lower mortality, avoiding of infections and other hazards, better prognosis in oncology, better patient satisfaction, better clinician satisfaction. And bloodless maintenance surgery is ethical, evidence-based. That sounds like what should be a standard of care, standard of care. We need to pre-plan, we need to combine techniques, not just one. Involve other disciplines and tailor our techniques to the individual patient using a protocol. And we emphasize education, not technology. This is an article from a Nigerian professor in nephrology advocating for the integration of bloodless medicine and surgery programs in the healthcare system of sub-Saharan African countries. And he says the bloodless medicine and surgery program is not for the sole service of JW group anymore, but for the generality of humanity. That sounds like standard of care. And he says, he quotes Dr. Isbista. Says the blood transfusion was previously seen as a gift of life, but the tables have been turned. The general perception now is that bloodless surgery and avoiding blood transfusion may be the gift of life. So, bloodless care in breast cancer care be the standard of care? I think we can agree that it is the best practice. It should be the standard. And I've listened to Dr. Spee's lecture on this, and I am convinced that so should it be. And so we have May as Bloodless Maintenance Surgery Awareness Month, because these are things which, even though they are published, they are not widely known. They are not widely known by many people. And this week we focused on bloodless care in oncology and palliative care. And of course, today is World Bloodless Surgery Day, May 16th, in recognition of the great work of Dr. Denton Cooley. On May 16, 1952, his first bloodless open heart surgery, doing the impossible, because they used like 20 units of blood or more, and now he was using none. So for this year, our theme is avoiding transfusion, saving lives. Yes, both the lives of those who decline blood transfusion and the lives of those who may not know better. We as clinicians, we know better, at least in some things, while not being paternalistic, but we use the knowledge that we have. Later in the year, we're going to see how medical informatics advances bloodless medicine. What is medical informatics anyway? We'll have some great scholars telling us about that. So in conclusion, blood transfusion is not a scientific option for any patient because of its adverse outcomes and lack of efficacy. And it's particularly bad in oncology due to immunomodulation. Bloodless care in breast cancer involves use of evidence-based techniques under 4 pillars, which are simple, safe, effective, cheaper, and result in improved outcomes. Bloodless care is the ethical, evidence-based option for all oncology patients, including breast cancer patients. And this is one of my patients. She gave permission for us to show this picture. This was on the last day of her radiotherapy. So we were celebrating the last day of her radiotherapy. She had had bloodless mastectomy, bloodless chemotherapy, and of course, bloodless radiotherapy. And she did not object to blood transfusion because of religious beliefs. She simply preferred the better outcome and to avoid the problems she had noticed in those who took blood transfusion. So thank you very much.
Thank you so much, Nathaniel. I think, and I'll confer with my co-moderator here, Heather, shall we hold questions for Nathaniel until our last presentation?
I think so.
Yes.
Okay, and I'll stand down. And Heather, do you want to introduce our last speaker?
Sure, I would love to. And thank you, Nathaniel, again for stepping in and giving that insightful talk and the importance of that bloodless, should be a standard of care for all patients. And, that's what we all strive towards. I now have the privilege and honor to introduce our speaker for the World Bloodless Surgery Lecture, Bloodless Liver Transplant with Improved Outcomes. And our speaker today for the last of this session is Dr. Angel Augusto Perez Calata. I'm hoping I'm pronouncing it correctly. And he graduated from the Universidad Autónoma de Veracruz, Vallarisa, and had his postgraduate training in emergency medicine from the Universidad Autónoma de Sinaloa, and his critical care medicine from the Universidad Nacional Autónoma de Mexico. He is the current head of critical care division and also the head of the multi-organ support ICU in Mexico's General Hospital of Dr. Eduardo Lagaga, sorry. Dr. Calata has been working with patient blood management since 2019. He's produced the Mexican PBM guidelines in 2020. He has interests in research in patient blood management, including coagulation management, viscoelastic testing, iatrogenic anemia, liver transplant, point of care, POCUS, GI failure, and several publications in ANA, biomedicine, chest, and many others. He's also collaborates in critical care books and PBM. He's a reviewer of the policy brief of the World Health Organization, and also founder and president of the SIA PBM, which is a society that aids in the implementation programs for Iberoamerica. He's also part of the scientific associates at the IFPBM since 2021. He's worked as a consultant in several hospitals in Mexico and Latin America for implementation of PBM. He is a family man who enjoys arts, adventure, and loves Asian culture. And I'm happy to introduce him to present this lecture to us.
Thank you very much for your kind presentation. I'm sorry to get you in trouble with the Spanish words. And by the way, it's really nice to see a lot of my medical heroes here. Dr. Bruce Pies, hi. I haven't been able to meet you in person, but I have read most of your work, so it's an honor for me to have you here. And so they asked me to talk. I mean, I know that probably liver transplant is not a part of oncology management, but Nathaniel, that was kind enough to invite me, and also I will be honored to meet you soon in person. Hear about what we are doing in liver transplant here in Mexico with patient blood management. So for this kind of approach, it's type of new for us. Or kind of new, as I commented, and well, as Heather kindly commented before, I have been working this. I'm one of the young doctors for PBM right now, so I have been working for almost 45 years in the program and in the project. And just to make sure, I mean, the global definition has been discussed in many other presentations for this amazing meeting of bloodless surgery. The importance is that we know, and one of the things I love about this definition is that we are making the patient our topic, our center, our everything. And I think this is a powerful, powerful message for every one of us. Because I heard Nathaniel in the presentation before me, that he's talking about that patient blood management is not only for people that do not accept blood transfusions, and this is the case for us because we are not religious bounded to anything, but we only believe really, really hard on the benefits of this approach. So the beginning, I'm not going to stop here because I also believe that everyone has mentioned it. The teachings of Denton Cooley about the management of bloodless surgery and cardiac surgery was the cut well, tie well, be well. And obviously these became the pillars of patient blood management. And they had mentioned also Professor Evister, that it's considered the father of all things. And we know that the patient blood management brand is made by his publication in 2005. And we all know the pillars of patient blood management, that optimize red mast cells, the bleeding and coagulopathy treatment, and optimize patient reserve. But when we talk about the evidence, and the evidence I think in liver transplant is right there. No, we still see in a lot of our hospitals and with a lot of our college, this trying to correct laboratory values instead of seeing what the patient really needs. And we all know of the meta-analysis and the association of pre-op anemia and mortality in surgery that we know increased risk in pre-op mortality, acute kidney injury, infections, thromboembolic events, and the increased risk of receiving a transfusion. But when we talk about anemia in the chronic liver disease, I mean, we have been working also with acute liver disease, but in chronic liver disease, that is what we are going to present today. We have a lot of problems. First, that we know we have multiple causes for anemia in this type of patients. We have inflammatory anemia. We have obviously micronutrition anemia, but we also have the challenge that we don't know when the patient is going to receive the call for a new liver. And this makes it in our hospital right now in Mexico. I mean, we have to say that liver transplant is being made only by around 5 or 6 hospitals around the whole country. So right now, the waiting list is really, really short. So, for example, this week we already did 3 liver transplants, and the patients were in the list about probably a month ago. So this reduces the time we have to treat anemia in these patients. Now, we know that also the increase in the viscosity of the blood that in liver is also really important, because increasing the viscosity of blood in patients with portal hypertension will increase the risk of bleeding. Then we already know that in liver patients, the risk of bleeding normally is because of the portal hypertension and not because of the alterations in coagulation. And we still have seen a lot of plasma use and platelet use with the we went to treat prophylactically, and just this we know that it will be a lot of harm in our patients, and even platelet transfusions. And this is an important study because we know that it reduces the 1-year survival of our patients, even if they need them. I mean, because sometimes they will need platelets, but still, I mean, sometimes if we use it prophylactically, then we have none of the benefits and a lot of the harm. So this also important study that makes us know that the exacerbations in portal hypertension will increase the need for blood transfusion, because it will increase the bleeding in these patients. So right now we know that blood transfusion, and if we compare it with 100% of the blood transfusions that we give, we know that only 11.8% of the patients will have a benefit. So we are talking really low benefit. That 59.8% of the patients will have a harm, and 28.9% of the patients are still in the gray area when you analyze the whole evidence of transfusion right now that it's circulating. So if we talk about number of patients, if we have a university of 10 patients, then we know the benefit is 1 patient, 3 are in a gray area, and 6 will have a complication or a harm because of blood transfusion. So with this publication done by Professor Hoffman about the PBM saving millions, when he summarizes that we have the ethics right now, the self-ethical obligation to adopt patient blood management as part of our daily life, that we have sufficient peer review evidence to adopt this approach to our patients. And obviously we have the economic speech about the benefits that it gives patient blood management, not only to our patients, not only to the physicians, but also to our health organizations, because they will save a lot of money. And obviously this has what we in Mexico call the 4th E, that it's the part of education. We need a lot of education right now to change or to shift the paradigm into patient blood management. Now, in liver transplant, right now we know that, for example, when we use plasma-containing blood components, we have computations such as graft loss, reduced post-transplant survival, and complications known for transfusion as TAC or trolley. When we use platelets, it's the most associated with increased morbidity and mortality, and transfusion-associated lung injury. And then when we use red blood cells, we know that we have problems with artery thrombosis, reintervention, reoperation, graft loss, postoperative infections, prolonged lung state, and all the indicators that the program says that it will benefit in our patients. So there is a need of transfusion limitation in liver transplants. And with this, the matrix of PBM, with the 3-pillar matrix, we know that we have around probably 100 and something interventions that we can do before needing a blood transfusion in the patient. So in this is when we adapt this 9-pillar matrix to our liver transplant program. We decide to go to the liver transplant in my hospital because in the early, when we started to implement the program, we needed an impact area that for our medical director in that time was the whole transplant program. And obviously, I mean, there were a few doctors that were already convinced they were into optimal blood use So we know they have a restrictive approach into these patients already. And because there were few, at that time, we only have one transplant team, some residents, and the pathology and the ICU care were already convinced that this approach was beneficial. So the educational part was extremely easy. And then we start to integrate some of the concepts. So we opened the anemia clinic for candidates of liver transplant. Then we acquire the viscoelastic technology. We start using cell salvage into our patients, and obviously try to control everything. And there was a continuum of care from the clinical part, from the pathologists that control portal hypertension, that refer the patients to the anemia clinic, and obviously they create a whole algorithm to treat these patients and to avoid complications in the anemia treatment. Then our anesthesiologist that, hopefully you will meet sometime, because she's an amazing anesthesiologist. And she started to do this whole process of controlling portal hypertension, reduced blood products utilization, having the viscoelastic testing, using the whole technology. And she was really into it. And then in the ICU, that for protocol, the patients at least had to spend some time after the surgery with us. So we use the avoid iatrogenic anemia, reduce blood sample utilization, and then we do the continuum of just watching how the patient behaves and have viscoelastic testing and everything there to avoid a trigger for transfusion. So obviously in the policy brief of patient blood management, they asked us to do a multidisciplinary, multi-professional team. And this multi-professional approach involved the hospital administrators. They were convinced of doing this approach with us, and they were extremely helpful. We work in a budget restriction country. So everything has to be really, really analyzed before they give us some money to do it. So we present the whole program, we present the whole concept, that they give us the support to acquire this new technology. And we have the laboratories that helps us out with the samples, and we are using microtrainer samples also, and closed loop tubes to get the samples to avoid iatrogenic anemia. And we have a representation with social workers that are, really, really close with the patients and help us out with the family to acquire and to understand what we're doing. And in the bleeding scenario, unfortunately, there's still a gap in teamwork, because everyone has a different approach and different objectives when we're talking about bleeding management. And probably this has been said a lot, but everyone that is into patient blood management is obviously more scared about thrombosis than about bleeding, because we know bleeding we can stop. The problem is thrombosis, and even a thrombosis in a liver graft is probably a death sentence, or normally could be a death sentence. So that's the reason we need to work together and work as a team and understand what are all the objectives of each one, and everyone understand then what they have to do. So in principle, when we are talking about patient blood management implementation and the quality framework, the done-obedient approach of quality, what we're trying to reduce also is this variability into medical treatment. So we know that, for example, when we have the competency that we're talking, that we have a good surgeon, a good anesthesia team, or a good ICU team, medical team, but it's only based on competency, then the variability in treatment will be extremely, extremely high. So that's the reason we establish a procedure and an approach with a process that will reduce variability. We know that anytime they do the surgery, anytime the patient goes into our ICU, the treatment is going to focus in the same objectives and will be done in the same way. But if we this process, we put it in a whole organization structure, then we know the variability will be done from the ER to the discharge of the patient, and again, the variability will reduce in what treatment approach is. So we know that 3 pillars are important. Again, the impact of treating the underlying cause of anemia in our transplant patients, that will focus on iron deficiency, folate, and B12. We obviously check for hypothyroidism in some patients. And even, for example, we know the correction of hemoglobin levels. We're using erythropoietin, and we probably will have a publication about the thrombotic complication that is always an issue, but we haven't seen it so far. I mean, not because of the erythropoietin. We have seen patients with portal thrombosis. And this is one of the other approaches that we love about our surgeon, the vascular approach. He also sometimes do a thrombectomy, and he has really good results in these patients without, taking it off the transplant list. Then intra, well, they try to do all the program approach in pillar 1, and then for our ICU, we'll try to avoid iatrogenic anemia in avoiding excessive testing. And this was the algorithm that we decided to use for these patients. So in the continuum of treatment, the first pillar, I mean, the use of the anemia clinic goes for pre-op, and then after the patient is going to be discharged, or even during the hospital length of stay, the anemia clinic is treating these patients and considering the whole physiopathological approach that they need to do to guarantee that the patient won't be anemic after discharge. Then in the second pillar, we use I mean, we do not correct, obviously, coagulation alteration. We will explain this. I mean, probably you already know, but we know that, I mean, the rebalance situation of the coagulation approach in liver disease does not need correction if the patient's not bleeding. So obviously, we avoid any prophylactic transfusion. Then we always value the patients that have a high risk of thrombosis, and the procedure planning and risk assessment is mandatory. Then we intraoperative this technology, the use of viscoelastic testing, the use of factor concentrates, including tranexamic acid. We don't use in our approach tranexamic acid prophylactically. We only use it when needed. We use a restrictive and goal-directed fluid management, cell salvage. We do not correct low platelet counts, except if it's accessed by viscoelastic testing, that we have to do so, and the patient obviously is bleeding. Control the temperature, the acid-base status, calcium, etc. And then when the patient comes out from the OR and into the ICU, then we never try to normalize coagulation again. If the patient continues to bleed, we use viscoelastic testing approach to see what they need. We also use concentrate factors as prothrombin complex or fibrinogen concentrate, and restrictive transfusion approach is mandatory. So when we talk about a rebalance hemostasis in these patients, we already know that the rebalance means that, yes, I mean, patients will have a small line for complication. I mean, if they bleed a lot, and if they have a thrombosis, the thrombosis is going to give us a hard time, because we know that everything decreases. I mean, we have elevated levels of von Willebrand factor and factor VIII, elevated levels of TPA, PA1, nitric oxide, and prostacyclins, and we know we have low levels of coagulation factors and inhibitors, so they both decrease. So in a way, and this has been already shown in different studies, bleeding incidence and portal vein thrombosis incidence that we know is an issue in liver disease. So I mean, when the balance is broken, and it's really easy to be broke, then yeah, I mean, it's going to be messy. We know that, and that's the reason we use this approach of of being completely untoward when the patient is bleeding, to control and to adjust what the patient needs, and avoid thrombosis. That is obviously a big part of our approach. So for the surgeon, and also the surgeon is an amazing guy that has we call him hemostatic hands, but the vascular control of the bleeding is it's one of the main approach that he has. So I mean, we're talking about putting a new organ together that has a need of vascular surgery, and I'm not a surgeon. I cannot give you the whole picture of what he does, but we know he does it. And probably in our publication that he's going to write the vascular approach or the vascular control approach that he gives. But he tries to avoid, a lot of blood loss during the reperfusion or the anhepatic part of the liver transplants. With the liver algorithm, we use this approach that we also know that we do not have to normalize coagulation tests in our patients. So we use this approach that it's a treat first, what kill first approach that we learned from Klaus Gorninger, and that I have been working together since we met. And obviously, we do not try, for example, to normalize the amplitude of the A5 in XSTEM to a normal range that we would use in another bleeding setting. So in these cases, we know we can go lower because of the rebalanced hemostatic situation of liver disease. And we use this approach for fibrinogen concentrate. So only when the patient have a A5 in XSTEM of less than 25 millimeters, then we use cryoprecipitates if we see that the A5 in the victim is less than 8. For the approach in platelet concentrates, it's the same. An A5 in XSTEM less than 25 millimeters, but an A5 in 15 that it's higher than 8 millimeters, then we use platelets. And it's a pleasure to say that we haven't used it still in the last probably 71 patients. Then for the correction of when we need to produce some thrombin generation, we give a preference to PCC, and we try to use a low dose of PCC. Normally, we are using around 10 or 15 units per kilogram. Only when we don't have, and when we turn to see fresh frozen plasma. Unfortunately, we haven't had to do that so far. And then sometimes because of the heparin-like events, we also consider protamine in some cases when we have a CT in intent and a CT in EPTEM that it's above 1.25 relation. And finally, then if we had a protamine overdose that we try to do not have it, then we use or consider fresh frozen plasma. Again, we haven't used it still, but it's part of our algorithm. And then we always rechecked. And this is important because then we value the clinical situation. And this is one of the parts where our anesthesiologist is really, really good at, because she's always checking how the bleeding in the surgical area is. So if she sees that the bleeding is getting higher, then she turns around and see the coagulation testing with ROTEM and starts to use the algorithms. This obviously to avoid over-treatment or over-transfusion or overuse of hemostatic agents. Then we give the clotpyrimids that we know that this is given by fibrinogen concentrate, the platelet concentrate. Unfortunately, in Mexico, we don't have factor 13 in our still in our hemostatic agents. I mean, we know there is a company that brings it, but we haven't been able to put it in our toolbox in the hospital. But obviously, I mean, we're trying to get there. And then we go to thrombin generation. Again, we give PCC as a first line for us. And tranexamics, again, it's only if the patient, or we see that the patient needed after the reperfusion stage, and the hyperfibrinolysis maintained for more than 10 minutes, then we use the tranexamic acid to avoid or to correct this hyperfibrinolysis. So we have the evidence about the use of viscoelastic testing in this area that we know is necessary and even helps a lot to reduce transfusion. And we know that we want to avoid or reduce transfusion in these patients. We know that, for example, when we compare it for using one or another viscoelastic testing, lysis is really, really good identified, especially by FIPT and with Roten technology. So that's the reason we decide to go with that technology. And obviously avoid plasma transfusion, a good correction and objective-based correction of fibrinogen is used. So we use a calculation of how much fibrinogen the patient needs when he needs it, and we only use those grams to complete target as fast as possible to ensure clot fairness. But obviously, again, we also want to avoid over treatment and go to the other side, that is thrombosis, because the whole team is more scared about thrombosis. And we all know why this is needed. This is something I already presented. We are checking always in the basic conditions. And this is also important because, the hemoglobin trigger is not something that we normally use. So we always see if the patients need it. So we have patients that comes out with, 5.9 or 6 grams of hemoglobin, but they are without mechanical ventilation. They don't have any vasopressors. The urine, uptake is fine. They can move, they can talk, they don't feel any symptoms. So we just start to treat for anemia without or avoiding a blood transfusion with these patients. And this is how we normally are managing in TRAOP. At least we know that the patient is going to come out with 6 viscoelastic testings to know that everything is being done correctly, and obviously also avoid massive bleeding situation in our patients. And we know with these factor concentrates, we also have no problem because this has been asked in the past, because there is low evidence about using factor concentrates apparently. But yeah, we know that neither fibrinogen concentrates or 4-factor PCC used alone and used without plasma will increase the risk of thrombosis or ischemic events. And the use of intraoperative cell salvage, this has been also one of, I think, the main reasons we are managing to do bloodless surgery in liver transplant, is that we are returning at least 50 or 60% of the blood loss to the patient in an autologous transfusion. So So now in the first pillar, we're talking about we continue pillar 1 and 2 in a continuum of care. So we know that the whole concept in the patient's journey in the hospital goes from the pre-acute care to home care. So again, we are using the first pillar in pre-acute care, and obviously a second and third pillar goes to pre-acute and post-acute care. We include in first pillar when necessary, and finally in the post-acute care we go again to pillar 1 and pillar 3 to protect the whole patient journey to the hospitals. So I'm going to talk a little bit of our results, and here I want to be really emphatic because again, this has been done for the past 1.5 years probably. So we are waiting still for the follow-up of 1 year survival to publish, and we still 4 months to go. So the numbers that I'm going to present are a pre-analysis, but this is the story of a liver transplant in our hospital. The first liver transplant was done in 2015, and from 2015 to 2018, they used the approach of mass transfusion protocols, so the survival rate was really, really low, and obviously this cannot be maintained in a liver transplant program. So from 2018 to 2022, they started to use the optimal blood use approach. So they only transfuse when the evidence or the clinical guidelines said that they had to transfuse the patient. So they use a little bit more platelets, a lot more plasma, and a lot of red blood cells. And the survival obviously increased in a matter of quality of the program to 85%. But then when we start to use the PBM program, and again, we implemented the 3 pillars of the patient blood management program, we were doing, right now we're doing about 60 liver transplants a year. And the survival rate we have right now is 98%. And with this data, obviously, the administrators were so happy that they helped us a lot more. So this is what we have done this is a comparison only of 50 patients when we started the whole program. So we see the number of 0-unit transfusion was really, really high. 1-unit transfusion was in probably 2 or 3 patients. 2-unit transfusion was only 1, and it was an acute case that developed hemophagocytic syndrome. So obviously, but I have to report it. Then we have more than 2-unit transfusions. We have never used it. Massive transfusion, we have never used it. And this is just a comparison of optimal blood use versus patient blood management. And fresh frozen plasma, never use it. Cryo, not a chance. And platelets also never have to use it in the patients. So most of the patients with this approach, that is a 6% transfusion rate in our sample, we reduce healthcare associated infections. We reduce the length of stay in the ICU. We have no thrombosis cases so far, and the mortality is close to 0. It's only 2%. And with the close numbers that we already have until this month of 1-year survival, our 1-year survival rate still in 98%. And because, there is also a problem that normally they don't believe us, that we're not transfusing in liver transplant. This is the table that the blood bank give us every 3 months. And as you can see, this is the transfusion rate of ophthalmology, and this is the transfusion rate of transplant surgery. So it can be done. So the conclusions are simple. Liver transplants present a rebalanced and stable homeostasis which oscillates between bleeding and thrombosis. So each subpopulation of liver dysfunction presents a specific hemostatic profile, and conventional coagulation analysis are not optimal to assess this hemostasis. Thromboelastometry offers advantages, and we should avoid prophylaxis with transfusion and always include bleeding and thrombosis prophylaxis in these patients. So in the take-home message is PBM has to become and is a standard of care. PBM is a quality standard, it's a security standard, and it's needed because the results are amazing. The 3 pillars are all important, and each one matters. So with this, I finish my presentation. And again, thank you very much for the kind invitation.
Thank you so much, Angel. I really appreciate it. It's inspiring work. Heather's back here too, so I think we at this point can take a few questions. There were 2 or 3 questions which may have been answered already. One was out of Nigeria by Dr. Ifat Adam Iwa, who asked about what's your approach to cirrhosis, and I think you probably answered that. But if you want, because I think there is a generalized opinion that patients who are cirrhotic are going to bleed like crazy. So maybe you want to make a couple more comments about that, and then there's one other question here also.
Yeah, in the approach, and again, we learned this from all our partners internationally. The bleeding, when we're talking about, especially, I forgot the name, but upper GI bleeding called from vessels. We know that, and this is caused by portal hypertension. And we also, this is not part of the presentation, but in this area, we also create a rapid response team for bleeding management in cirrhotic patients. So we are doing the approach that we are really connected with the interventionist and with endoscopy to stop the bleeding. That is the main part. I mean, everything about coagulation management and everything around patient blood management, if we do not stop the bleeding, then everything will fall apart. So we create this rapid response stream from the emergency medicine to the ICU. When we have a cirrhotic patient that it has an upper GI bleeding, goes right to endoscopy, then they try, or 98% of the time, they succeedingly control the bleeding. If they can, then it goes to interventionist radiology for them to obviously try to stop the bleeding. And we use the same approach. I mean, we are using viscoelastic testing to see if there is a coagulation need of correction, and we avoid the red blood cell transfusion until the patient dropped more than 60% of the hematocrit. That probably is when we use 1 unit or 2. Sometimes, I mean, most of the cases we don't use transfusion. And one of the important things in this part, if you see the international guidelines, they say that there is no endoscopic emergency. So the endoscopic part of controlling the bleeding normally says, okay, control it with balloons or whatever. And when the patient is stable, then you can bring this to us, and then we control the bleeding vessel. So this approach with our endoscopic guy, that it's really, really an amazing and, you know, high adrenaline junkie also decide to do the other approach. And when they start to do this, they have a 85% probably mortality in the endoscopic area, in the endoscopic room, in massive bleeding patients. When we start the code, the rapid response team, then we completely send the survival rate to 85% right now. So we have a really, really good approach. Also, it's a work in progress. They want to publish it, but the results were amazing. And we are also using patient blood management. And in the educational part, we also convince the ER doctors and because again, we are trying to implement the process in the whole hospital. The ER doctors and gastroenterology ward right now do the same, the patient blood management approach. So they do not transfuse plasma or platelets to correct, you know, parameters in the patient. They try to guide everything with viscoelastic testing assessments, and they are really, really trying to be extremely restrictive. I mean, they don't go as far as we go as 6 of hemoglobin, but they try to go from 7 or higher, but do not, I mean, from 7, they trigger the red blood cell transfusion. We're still talking about this in some patients, but I mean, they're getting there. So that would be the approach that we do for cirrhotic patients, but definitely no prophylactic approach of plasma or platelets in these patients.
Thank you. There are 1 or 2 other questions, several from a Dennis Novick. One, he's asked about any experience, any knowledge of using ligenesis implantation of donor liver cells into lymph nodes to have exciting new growth of liver type cells in lymph. Do you have any comment on that? I certainly don't know anything about it, but maybe you do.
No, I have to say I don't, and I have to also say that in my hospital, liver donor approach is not been done yet. They are working on trying to open that approach also, obviously. I mean, 100% of our cases come from cadaveric donors right now. And as you could see, the program is really, really young in our hospital. I mean, we are talking about 7-8 years that we have been working in liver transplants. So yeah, no, I for my part, I mean, I'm an intensivist, so I have no idea. But if I can give you my contact, and I will ask the surgeon if he knows anything about it, for sure.
Thank you. Heather, anything more from your side?
unmute there. I was just looking to see what else was in the Q&A there. There's a question, what are a basic manager for blood transfusion of patients with hemolytic conditions and adverse conditions, allergies, as well as the diseased organs?
Yeah, I'm not really sure where that question's going, but
No, I'm wondering if the person can speak to it, if they're online. Ebenezer?
No,
And the
I would-
next one's in Spanish and I can't read it, unfortunately.
So
I've
maybe we'll conclude there with the questions and thank our speakers. Nathaniel, there's lots of clapping and thrill for your talk, as well as requests. Can people get some slides? I suspect there's probably going to be a demand for slides from many of these presentations because they're all so wonderful, and most of us would like permission to be able to reuse and review some of them. So maybe for those attendees, Nathaniel, you can send out ways that people can receive various presentations. I know they'll be on YouTube and elsewhere, but thank you to all of our speakers today. I really appreciate them. I would encourage everybody to stay on because we have one more very special event, which I think, Heather, do you want to introduce her? I certainly can.
I'll let you.
Okay, I know Dion, and she's going to give us a an industry-based discussion here. So I would encourage everybody to stay on for another 15 or 20 minutes because I personally find this very, very exciting. I have known Dion Ozumwenji for probably the better part of 8 to 10 years here as she and HemoClear have worked towards devising really unique new technology. Unfortunately, we haven't had Jonathan Waters on speaking for us today about cell salvage, but the technology that she and Arno Nierak from the Netherlands have created is a filtration system that is fairly low tech, but highly effective. And although I sound like I'm giving a commercial endorsement here, all I can tell you is I've both known Dion as well as worked with our technology on some benchtop research, and I've pushed it out to many people saying, I think this can revolutionize medicine. So, and I think it should be a consideration for many of us in our patient blood management world and in our bloodless surgery world. So, Dion, without further ado, let me have you give your presentation, and hopefully this will generate some good questions as well.
Thank you so much. Yeah, thank you so much, Professor Spies. It's always a great pleasure to see you online. And it's been a long time indeed since we've known each other.
I think it's close to 10 years.
Yeah, you forget while you pass through time, but it has been a long time. Thank you so much for the kind introduction. I'll go ahead and share my slides with you all. I hope technology is working with me today.
It's starting. It needs a couple seconds.
Okay.
It says you started sharing your screen, so maybe there you go. Now it's there. There we go. Perfect.
There we go. Okay. Thank you so much. Like I said, it's such a pleasure to always be here at the event, to see you all online, and to be able to share a little bit on HemoClear and as we get together 2 times a year for the Bloodless Medicine and Surgery Society, I think more and more people know HemoClear. So I'm always particularly excited to share what we're working on and what we have been working on the last, let's say, 6 months. So I'll do the same today, but I'll start from scratch as usual. When we talk about patient blood management, and these are the things that you all know much better than I do, we all recognize the 3 pillars, and also the fact that cell salvage is an important part of the strategies to conserve the patient's own blood. Like I've already said a few times, and what was the basis of the idea of HemoClear that Professor Arno Nierich came up with was that although there's a great awareness that cell salvage can be very beneficial clinically speaking, the lack of simple and affordable cell recovery technologies that produce high quality blood that is washed rather than just filtered is a limiting factor for the support of patient blood management worldwide. We all know the centrifugal devices that do a fantastic job at recovering and washing the red blood cells, but there's also some downsides because the technology is complex, it's costly, and therefore usually confined to the settings where the investment could be made. But there's also a lot of settings where these centrifugal devices are not available, especially in the lower resource setting. So HemoClear was invented. Yeah, there we go. HemoClear was invented as a solution to extend the use of cell salvage to support the centrifugal machines anywhere where that was necessary. So it's a microfiltration system that processes the shed blood in a gravity-driven procedure that is accessible, it's easy to use, and in contrast to the centrifugal devices, no equipment is needed. The cells are also washed, so high quality. And as a bonus, with the red blood cells, we also recover about 70% of the platelets, which in some situations is very relevant. The system is used in 3 steps, like you're also used to with other types of cell salvage technologies. The first step being collection, obviously, and this is performed with HemoClear in exactly the same manner as one would do with a cell saver. Then in case of HemoClear, for processing, we would filter the blood simply by filling the first blood bag of the HemoClear system and hanging it above the filter device that you see in red in the middle picture. And the blood is washed and filtered in 2 consecutive rounds that together take 10 to 25 minutes, depending on the hematocrit of the blood. And after those processing rounds, a fresh unit of autologous washed patient own blood is given back to the same patient in the 3rd reinfusion step. Now, today and during last talks as well, I zoomed in on the use of this technology in obstetrics. And the reason for that is reports, especially in the lower middle income countries, that obstetrics consume a very high percentage of the donor blood that is used, up to 40%, I hear. And because in the lower resource setting, postpartum hemorrhage and anemia in pregnancy still greatly contribute to maternal mortality. This is well described in literature and explained by the leading physicians among us here today. Taken together, we feel that obstetrics might be the indication that maybe even has the biggest benefit when it comes to implementing HemoClear. When I say implementation, I immediately get to the topic of some of the exciting things that we're working on today, because this HemoClear system has been CE marked, it's validated for the safety, but also clinical effectiveness. But we all know that it takes more to effectively implement and facilitate adoption of new technologies in healthcare. And one of the factors that have already been researched is the health system requirements. But in addition to that, adoption requirements are also very, very relevant. So in addition to clinical effectiveness, we also ask ourselves the questions, does the technology integrate well into the current transfusion practice? Is it financially feasible? Is it what is the best route to implementation? What is the best plan? What clinical guidance is needed? So to get answers to the questions that we ask ourselves, we currently have a few trials running. I now grab the ones in the obstetric setting. 2 weeks ago, we started, or a trial was started, actually, not we, in Germany. And that one focuses on the use of Hemoclear in elective cesarean sections, and mainly also compares on the recovery of platelets and how functional are those platelets and what does that mean for the patient. So that's still in the looking at the clinical side. In South Africa, there's a trial that's halfway through, also looking at the use of the system in cesarean sections. And we have a trial in Nigeria that I have to firstly say, when I say we, I have to say that it's a collaboration between Hemoclear, the National Blood Service Commission of Nigeria, and Fit Fund. And this trial not only looks at the clinical side and the clinical effectiveness, but also takes a look at the implementation side and has an implementation research arm in it. So it is a clinical real-world trial of microfiltration cell salvage, and it focuses on the obstetric setting. It's aimed at understanding the optimal method of implementation of cell salvage by microfiltration, and how to successfully adopt it in the lower middle resource setting. There's a target enrollment rate of 300 women that undergo OBGYN procedures in one of the two research sites, which are University of Calabar Teaching Hospital and University of Abuja Teaching Hospital. And in addition to these clinical participants, there's also implementation participants, which are actually the healthcare staff that provide the implementation data in form of their feedback on how the implementation is going and what is needed to get it to the highest level and the best result. And today I was drafting these slides, and I had to really sit down and think about what captures the results that we found so far, because we were there a couple of months ago to join the National Blood Service Commission on the initial trainings, the onboardings of the clinical investigators, and we saw something that I found quite remarkable. So I say unlocked success in the first trainings, and the remarkable thing is that, and this is something that is good news and bad news at the same time, the context that these hospitals are in and the implementation participants are in show that they are towards the far end of the spectrum when you look at suitability of implementation, because everybody that was involved was so highly motivated. Even though the current use of autologous transfusion is very limited, there was excessive knowledge of the concepts, a very, very pragmatic attitude, which is remarkable also to be stirring. Well, theory is also important, I recognize, but the pragmatic attitude very much stood out, and strongly solution-oriented. And then the only bad thing is that there's bias when you look at the data, because this is not representative for settings where this context is different. However, the good news, obviously, is that all of these first findings contribute to the outcome of the first trainings, which was that it was just a brief training consisting of some theoretical background and practical instructions that enabled healthcare practitioners to successfully set up and demonstrate the use of cell salvage. So next steps in this pilot is the actual phased implementation of the technology in the obstetric and gynecology department. And that will consist of larger scale training events of anesthesiologists, surgeons, hematologists, OBGYN consultants, nurses, midwives. And during those training events, implementation data will be collected, and that will be quantitative data, time measurements on the task to, for instance, set up the microfiltration technology, some exam questions, but also qualitative data, collecting subjective opinions from everybody that's participating on the training program, but also on the use of the technology and the features, etc., so that the training program for the second event can even be optimized on the back of the feedback of the first event. So I'm very hopeful that for the next meeting, I'm trying to be in the present time, but I'm hopeful that the next time we see each other online, I'll be able to share a few more insights and results on the outcomes of this wonderful endeavor. That's it from my end for today. Thank you very much for listening, and please let me know if you have any questions.
Questions? Anybody have any questions for Dion? I think. Thank you, Dion. I also want, as my screen all of a sudden decided to go small, so I'm not sure how to get rid of that and get me back to full screen. But if there aren't any questions for Dion, or if somebody has them, I can't see the chat because my screen went so small. But if somebody wants to speak up and ask a question, go right ahead. Otherwise, I wanted to give
there are a couple of raised hands. There's one from among the panelists.
Thanks. Go ahead, Nathaniel, because as I said, my screen just suddenly went small, so I'm having troubles trying to get back in control here.
Dr. Naku, you can unmute yourself.
All right, thank you very much for that presentation. That was wonderful. Just wanted to know if this procedure has any effect on the quality of blood. We had a patient who had a leaking ectopic, and we are taught perhaps that intraoperatively we could salvage some of the blood, but the surgeon on getting in there say the blood was not of good quality, and so he didn't use it. So does it have in purifying the blood? I don't know. What really does it do? Yeah.
It's an important and great question. Thank you very much. So the function of the technology basically is to capture the healthy red blood cells and platelets and separate it from anything that is non-cellular contaminant by washing. So it kind of depends on what was wrong with the blood. If, for instance, the hemolysis was too high, then the technology would get rid of the hemolysis by washing it out, like a cell saver, reducing the level of free hemoglobin, etc., to increase the quality to such a level that it can safely be reinfused. And if you're interested, I'm happy to share some research papers maybe on it if you like to read more. But yes, the purpose is to separate the cells to have only the qualitative parts to give back instead of it being mixed with anything that's potentially harmful to the patient.
It's actually very ingenious technology in the way that the stack of the particular filters and the right pore size is put together to keep red cells and platelets, good red cells and platelets, and discard the rest. It's really pretty ingenious. On that note, I think there's one more piece of business. Thanks, Dion, for your input, and thanks for the questions. There's one more piece of business. Linda Shore-Lesserson has joined us, and I'm not sure where she is in the world right now, at which one of the many meetings she attends, but Linda wanted to say a few words here, I think, as president of SABM. Is that the role you're filling at the moment, Linda?
Well, Thank you very much, Bruce. Yes, I'm president-elect of SABM. September, we will turn over the presidency. And I just wanted to make sure I spend a little bit of time with you, hopefully today and tomorrow. I want to thank you, the whole organization of Bloodless Medicine and Surgery, and Professor Nathaniel Orso. We are so privileged to be able to work with you, touching the world the way you do for the sake of bloodless medicine and surgery. And just what I've seen today, just what I've seen this past hour is really wonderful advances in our capabilities and what you're doing for palliative care and oncologic care, and for those who really prefer bloodless medicine. We look forward to working with you in the future. I look forward to spending an entire meeting with you rather than just a few hours. But thank you, all of you, and especially Professor Nathaniel, for all the work that you're doing with your society to touch the world.
Thank you, Linda. You are the professor. I'm here to get there.
You're the magic behind the organization.
Thank you.
I think that thanks, Linda, for making the time and effort to be here, and we do look forward to being with you in Phoenix in September, a place that I could practically walk to from my house here in the desert southwest of the United States. I think I'm gonna be quiet, and maybe if Heather and Nathaniel have a few concluding words to say from this morning's conference. Thank you to everybody, and I hope you have a good evening, day, wherever you are in the world.
I think one last thing, I just wanted to ask if there was any of the panelists from today, if they wanted to make any comments or give any feedback or have any questions.
So while the panelists are thinking, I think there are a couple of hands in the audience. I don't know whether they wanted to say something. We could unmute them. There's Tafa.
Chat box.
Tafa can speak now.
Yeah, I don't have anybody in the chat.
There's a Mark Rochester, whose hand is up.
Okay.
Good morning, or good afternoon, or good evening, depending on the part of the world that you are. Are you hearing me?
Yes, very well.
Okay.
I'm sorry, I moved him to panelist, so maybe it has interrupted his network. And there's Dr. Sani and Dr.
Okay. Are you?
Oh, okay, you're here now. Good.
Are you hearing me now?
Yes.
Okay. If I can get this thing working. Dr. Sur, I'm not sure if this is an appropriate time to speak. We can put it off till tomorrow or another day if you like. I'm just giving you the opportunity to allow me to speak if you want me to.
Okay, if you want to make a comment on the meeting or ask a question, you're free to do so. We still have about half a minute.
All right, so I just wanted to commend you, Dr. Nathaniel Osoro, and your organization, your society, for putting on this excellent World Bloodless Surgery Day. It has been much needed. It has been overdue. I appreciate all of the doctors, the surgeons, the medical professions, your regular people, everybody for contributing to this week, starting Monday gone. And it's going on until Saturday coming. So I'm just saying it's been a wonderful experience hearing everything, and the mission of accomplishing people being aware of the benefits of bloodless medicine and surgery not just for the medical professionals, but the general public, for them to be knowing all of this good stuff, the benefits as opposed to blood transfusion and the dangers and risks with blood transfusion has been amazing, excellent, wonderful. On behalf of the people here in Jamaica, I'd just like to say thanks very much. And we hope that the rest of the week and the rest of the month will continue to be as successful.
Thank you so much, Mark. I appreciate that.
Another time we'll talk about something else,
Sure.
about some experience in Jamaica with bloodless surgery.
Thank you, Mark.
Thank you for having me.
I think, is it Tafa? Do you have a comment that you want to bring forth?
And there are also some surgeons from Malaysia, Dr. Sani and Dr. Faishan. If they wanted to
Hello.
make a comment, yes.
I'm Dr. Faisham from Prince Court Medical Center. Previously, I'm from University Hospital. I'm doing orthopedic oncology. Because everything is about breast cancer as well as blood transfusion and liver transfusion. There's nothing to share about orthopedic oncology. I like to share a bit comment, especially in our orthopedic oncology, the importance of bloodless surgery, visualizations of the margins and to avoid contamination is important in terms of prevention, local recurrence, and survival outcome. So how we do that? Wide margin, compartment resection, avoid marginal tourniquet, hypotensive anesthesia, which is very important, correlation with anesthetics, and of course, same like a breast cancer surgery, neoadjuvant chemotherapy, and absolutely good diatomy and sticker clip. So that's the whole entire things that I can share. I did prepare a few slides, but I don't think that time is for us tonight. Then that's it, my comment in orthopedic oncology. Thank you.
Thank you so much, Dr. Fashion. Dr. Tani, did you have any comment you wanted to make?
Yes, hello, hi. Thank you for having me also, Professor Osoro. I'm Dr. Sani from National University of Malaysia. Likewise, my great teacher, Dr. Faisham. I'm also practicing orthopedic oncology, and I would like to echo what he has said about our aim of doing a bloodless surgery is to get margin, also to avoid contamination, especially in a tumor surgery. So basically, what he tried to emphasize is what we are practicing, especially in Malaysia. And it has been our practice since then that bloodless surgery has always been our aim, especially in tumor surgery. Yeah, that's about from me. And
Thank you, Hafiz.
thank you, Dr. Sir, for having me, and all of the panelists and the speakers.
Over to you, Heather and Bruce.
I think that concludes for today. As far as I can see, everybody's had their chance to comment, and we have one more day tomorrow. That's correct, Nathaniel?
Right.
Yes, that's correct.
And do you want to share the program? We can just give the overview of tomorrow.
Yes, certainly. Shared just now. Okay.
Perfect. So for tomorrow, which is our 5th day of this wonderful week, we're going to start with a keynote address, minimizing blood loss in cancer surgery for better outcomes. And the second talk will be bloodless care complementing palliative care nursing. And then we'll have a final panel discussion of tomorrow with avoiding transfusion, saving lives with Sherry Azawa. So please stay tuned for tomorrow's exciting talks. Bruce?
Nothing further from this far side of the world. Thank you again. It warms my heart to see so many people getting on board and finding the science behind avoiding transfusion, and not just avoiding transfusion, but taking the best possible care of patients that we can. There's more data coming out, some of which will be published within the next month or so. I can't tell you all what it is yet, but it will amaze you and just confirm all of what you already know, which is that patient blood management and these bloodless techniques can really advance mankind. What I'm getting towards is an editorial that I've written for some very big work that's coming out of Johns Hopkins. And the data will show that we right now have potentially the biggest future impact in medicine other than the advance of penicillin. If you can imagine that by doing this technique and technologies and multiple technologies and people cooperating, collaborating, we can reduce mortality, all comers to all surgeries, by over 50%. That has never occurred in medicine, and that's what's about to occur. So the discussion that Nathaniel had about ethics is absolutely spot on. If we don't do this, ethically, we're morally inept. We have to do this. All of medicine has to do it. So I'll get off my preaching and just say thanks again. Stay tuned. The scientific data is gathering. The train is leaving the station. It's going faster and faster.
Well, thank you very much. Heather, you want to say bye-bye to everyone?
I would be happy to say goodbye for today. And I guess we're going to close this session for today and look forward to more talks tomorrow. Thank you.
Absolutely. Thank you. Bye-bye.
Bye.
Thank you all.
Thank you. Bye-bye.
Thank you. Bye-bye.
Thank you all.
Thank you, everyone.
everybody.
Thank you.
One more thing, please. We're supposed to take I'm sorry, I forgot this. We're to take a gallery, a picture.
Yeah.
So please, all the panelists should stay on. Let's put it in gallery view and take a picture. Bruce, I hope you're still there. He has logged off. I'm sorry, I forgot to mention it. So Migo, can you put on gallery view?
I think she also left.
Oh, okay, let me see. No, he wouldn't have, he shouldn't have. I think it's in gallery view right now, right? He's here.
It's me who put it, yeah.
Oh, okay, great. So can we all turn on our cameras and then turn on a smile? Let's take the gallery view. All of us can take the pictures, can do a screenshot, please. And then next, we'll then see who is the best photographer. Okay, please smile. Okay, great. Thank you, everybody.
Thank you.